Ketamine for airway management, toolboxes, chainsaws, and MacGyver. So I was at the gym the other day and trying to decide what CME I was going to listen to. And I came across Ruben Strayer's site, Emergency Medicine Updates, a great site. This month's post was ketamine-only breathing intubation. It begins with a 9-minute video. Ruben with a resident demonstrating this procedure. And thanks, Ruben, for sharing this video and, more importantly, sharing your views on this topic. Now, on the bottom of this page, there's an algorithm, and it describes where they feel the use of ketamine should be in terms of airway management strategies. Now, there's a little asterisk at the bottom of their page, and it says some airway experts disagree. And when you click on that, it takes you to a post I did, Awake Intubation in the Emergency Department. Now, I'm definitely not a ketamine hater. I use ketamine probably more than most people in my department. I'm probably referring to statements I've made that I don't believe that we should call the use of ketamine when it's employed primarily as an awake approach. I do like the term dissociated awake intubation, but that term's been used variably by different people, and I'll get back to that later on. So this is the paper by Andrew, Michael, and Ruben, and congratulations for doing this. As they state in this paper, there's very little literature to support the use of ketamine as part of airway management, but they describe things in detail and present where they feel this approach should fit in terms of airway management strategies. Now, what do they mean by ketamine-only breathing intubation? It's the use of dissociative dose ketamine to facilitate intubation in a spontaneously breathing patient with or without the addition of topical anesthesia. So that's the definition they use. Various definitions that are out there, terms that are out there describing the use of ketamine for facilitating airway management. The one that we've used, and the one I'm going to use for the remainder of this talk, is ketamine facilitated intubation. Now, if you don't hear anything else as part of this post, this is at least one of the most important messages that I have about this topic, is that there is a distinct difference between an awake approach that uses ketamine. And what I mean by an awake approach that uses ketamine is that the awake portion really refers to the fact that your primary intervention is aggressive meticulous topicalization for both laryngoscopy and intubation. And you may or may not use ketamine along the way. And that's different than a ketamine approach that uses topicalization, in which the primary intervention is the ketamine, and then you may or may not use topicalization along the way. And both of these are very different from deep sedation or sedation-facilitated intubation. Now let's go back. Let's look at history. We began airway management in emergency medicine with blind nasotracheal intubation on the breathing patient who presented, and then orotracheal intubation in the dead. And that was back in the 1970s. Then we moved on and we figured out we needed something a little bit more broad to address our different patients, and we adopted sedation-facilitated intubation. Again, what are we doing? We're using Valium, morphine, and muscle to get the tube in. And around that time, RSI came into the emergency medicine world, and certainly through the 1990s until now, RSI has become the primary approach for airway management in most emergency venues. It wasn't really until the 2000s in which, at least in emergency medicine, we started talking about awake as an option in a similar way that they do in the operating room. And that's why I have it in brackets here. And since then, the awake has gained a little bit more prominence, and more emergency physicians are using it. There's also this thing that I'm referring to here as the pseudo-awake, and I'm not suggesting we have a new term. We've got way too many terms out there to begin with. And what I mean by a pseudo-awake is people are taking the old deep sedation facilitated, modifying it, trying to keep the patients lighter to facilitate intubation. That's certainly happening with fairly significant frequency, I think, around the world, particularly in North America. And then there is what I think is a distinctly different approach, although some might argue that there's ketamine-facilitated intubation. All right, so what are the real-world options that are out there? Many people will refer to the crash intubation, and all of us, we all might have different definitions of what that means. But I'm talking about the arrested patient or the profoundly hypotensive, unconscious patient that you have to act now. And it is a relatively small population in the ED. It certainly happens. And sometimes you do have to use medications to facilitate that. But for the great majority, you can just place the endotracheal tube or whatever airway intervention you need to. And I'm not going to talk about that in any more detail. The two most prominent approaches that are discussed in textbooks and courses and what algorithms are relevant refer to either a rapid sequence approach or an awake approach. But in the real world, other things are happening. So we know that deep sedation or sedation-facilitated intubation is happening, and that ketamine-facilitated intubation is happening. I think it is important to realize, and I think it's unfortunate, that there are no guidelines for emergency medicine. Most of the guidelines for airway management of the difficult airway are anesthesia-based, and they're aligned with nationalities. I've said this before, and there's nothing really different between an Italian airway and a German airway, and there are efforts to consolidate all of these national guidelines into one. And you can email me, and I'll tell you more about that. But hopefully that's going to come into play over the next year or two. The guidelines that currently are most relevant to emergency medicine are the DAS critical care guidelines. So guidelines for the management of tracheal intubation in critically ill adults. I think this is an incredibly important document. And obviously we share a similar cohort of patients with our critical care colleagues. And I think almost everything in this document can apply to emergency medicine, including discussion about human factors and the approach to intubation and airway management. Now, within this document, they do say is that the recommended approach is with the use of paralytics as part of a rapid sequence intubation, recognizing that if you're concerned that the patient may pose significant difficulty, that an awake approach should be undertaken. Our guidelines that we use when we teach, similarly, you begin with an assessment of the patient's anatomy, their pathology, and their pathophysiology. And then you make a decision whether they're going to be difficult to intubate. You assess their cooperativeness, their ability to cooperate, and ultimately that impacts your decision to do either an RSI or an awake. Now, there is another option here, and I'll address that later on. But again, primarily, it's been awake versus RSI. Yet in the real world, the most common approach that we use is to perform an RSI in emergency medicine. And how have we been doing? Well, you know what? Not too bad. First pass success rate, if you believe that that's an important metric, and many will debate that's the one that's out there. Systematic review and meta-analysis of first pass success rate in emergency departments. What's the benchmark? 84%. We've been saying that for years before this came out, aiming for 85% first pass success rate. Now, with some groups, they've been reporting extremely high success rates in the order of 98%. Most of us are familiar with the driver study, which compared routine use of a bougie with a stylet approach. And they were primarily using a Macintosh video laryngoscopy. And only about 50% of the time were they actually looking at the screen. But the more important metric than first pass success rate is first pass success rate without hypoxemia. And overall, their first pass success rate without hypoxemia was 85%, and those with some features of difficulty, it was 82%. And compare that to that was in the routine bougie use group. Compare that to the stylet group, again giving significant support to using a bougie routinely when doing an emergency intubation. I think actually the best metric to use is first pass success rate without hypoxemia and without hypotension. In fact, I'm medical director of our critical care transport program, LifeFlight here, and we have a first pass success rate without hypoxemia, without hypertension of about 85%, and that's using old-fashioned equipment. So, as I said, we're doing it pretty well. We've got high first pass success rates, but the reported complications in the literature are a bit more concerning, with desaturations anywhere between 19 and 70%, and post-intubation hypotension happening anywhere between 23 and 46%. So the pendulum has swung, or has been, in RSI's court, but it's not without significant consequence. So why is awake intubation in the emergency department so uncommon? As I said, if you're presented with a patient in your department, we look at that patient, we assess their native anatomy or what presenting pathology they have. We look at their physiology and we try to make a decision, an informed decision, whether we're going to do an awake approach or an RSI. The most common reason why I'm doing an awake approach these days is because of the physiologically deranged patient, which isn't that uncommon, and particularly the apnea intolerant patient. And what's nice about that is that now I'm doing a true awake approach more frequently so that I can employ that technique with a higher success rate when patients present with significant pathology. But the real reason why most people cite that we're not doing very many awakes is because of patient cooperation. And there's no question that that is an issue. Our patients, you look at them, the significant respiratory failure, burns, whatever it is, you can say, I might do an awake, but your assessment is that you don't think that this patient can buy in and they're going to be cooperative enough for you to topicalize them properly and proceed. I continually, learn new stuff, and that's what's wonderful about medicine, is remaining curious and being willing to change your approach. And what I've come to learn over time is that I was way overcalling a patient's uncooperative state. And I've done awakes where I'm just using anxiolysis and primary topicalization on morbidly obese patients with sepsis, on burn patients, on trauma patients, penetrating neck injuries, respiratory failure patients. Occasionally, yes, I'm going to have to dissociate that patient, but I go in with an approach that I think I'm going to be able to topicalize this patient and potentially do laryngoscopy and intubate this patient without the use of systemic sedatives. I'm going to get back to that a bit later. So the question is it really an option, right? Is it really an option because of the fact that so many of our patients are deemed uncooperative? I've said this before, is that you can't call it a toolbox if you only have one thing in it. And you might start off with multiple things in your toolbox, but if you don't use them regularly, they're not real options. So again, if you're just have the skill set, the equipment, the drugs to do an RSI, then you don't really have a appropriately stocked toolbox. Are you playing the odds? That's the question. So when you look at a patient and you're trying to decide, what's your approach? Well, you look at them and you make a calculated decision. It's a risk versus benefit scenario. And we do that every day in emergency medicine. And that's very different than are you gambling? So what I mean by are you gambling is your decision based on the fact that, you really don't want to do the awake approach because you haven't done it and you don't really think you have the gear. And so, and you say, geez, I'm pretty good at doing an RSI, so I'm just gonna go for it. And then you do it and you're successful, and that reinforces that behavior. Please recognize that often that's not playing the odds, that's gambling, and potentially that's going to come back to bite you, or more importantly, bite your patient. And this is the difficult airway paradox. The difficult airway paradox is that, think of it, you've got a patient that has a big branch in their neck or whatever, poses some difficulty. Now you're supposed to potentially do a procedure that you don't do very often, a technique that is technically more difficult, and yet have a high success rate. And that's a real challenge. There's ways to overcome that challenge, and that includes recognizing that early and calling for help. Calling for help doesn't mean that you're surrendering the procedure. And perhaps I'll talk about that at another time or a little bit later. But we have this fragility bias, or this fear of failure. And it influences our decision making, no question. Adams is a guy who in the 1970s described a psychomotor feedback loop and how we learn various procedures. Let's take you through it. So let's assume we're doing an awake approach, and we've got a terrible view, right? We've got a grade 3 epiglottis only view. And so, we have certain sensory information that's being fed back in terms of the force that's applied and the sound of saturations in the room, and all the sensory information has to be perceived, and then you alter your approach, usually most often by trial and error, and you have to have what he calls knowledge of results, and that's sort of fed back as to, did you succeed or did you fail? And when you've failed and you still end up with the result that you began with, unfortunately, that can precipitate this avoidance pattern, right? Where you've tried this procedure that you don't do very often, it wasn't successful, and therefore in the future, you're potentially going to avoid doing that procedure. So in order to really have options, you do have to make sure that you've got your toolbox with the right gear in it. And in terms of the awake approach, it's really not that big of an issue, and I just don't buy it. Simply don't buy it. That the hurdles are so big that you can't get a tongue depressor, 5% ointment, a proper atomizer, and 4% lidocaine. And this is not expensive, right? So make sure you have the right gear so that you can actually call it a toolbox. What we end up doing otherwise is we end up taking shortcuts, right? So we use aerosolized lidocaine, 2% or even 4% at low flow. And I can tell you, this doesn't work. It's not going to work with this anywhere near the same effectiveness as using an atomizer. So again, we're taking a shortcut. If you use 2% gel as opposed to 5% ointment, it's taken a shortcut. If you use 2% instead of 4% aqueous, it's taken a shortcut. And Laura Duggan wrote a beautiful piece and talked about MacGyver bias. What that is that you take shortcuts and you don't have the appropriate gear and the appropriate equipment, so you hobble together what you have, and you might even invent a new approach. And it's not evidence-based, and unfortunately, most often, you're setting yourself up for failure. Take a look at this article, MacGyver Bias. Congratulations, Laura, on a really nice paper. A piece about topicalization. This is the device that we use. So it's not about having the right drug, too. It's about having the right gear to deliver that drug. This is an atomizer that gives you a controlled release when you depress the proximal portion with your thumb. It's hooked up to 8 liters of air or oxygen, and it's got a directionable tip. And this is way more effective, I think, than using a syringe-based atomizer, where you just don't have nearly the controlled delivery as you do with this device. So again, don't take shortcuts. Make sure you have an appropriate atomizer. And I think that we are setting ourselves up for potential failure. Take the effort, right? Find the gear, find the right drugs, ensure that you have access to it. And then ultimately What's critical is that you have the skills to employ this technique. This is from our textbook. It's a free open access textbook that we update as new evidence and experience comes into play. aimairway.ca/book. This is the Awake chapter. Ian Morris, Adam Law, and myself. And Ian and Adam, I believe, are two of the world's experts on the Awake approach. And this is the technique that we use here in Halifax. And there's no question there are other cocktails out there. But I'm not going to go over this in detail. Spend some time on this site. There's tons of video. It's very detailed, and I think is an important resource if you want to learn how to do an Awake properly. So again, as I said, make sure you have the right things in your toolbox to have the right options and make an Awake approach something that is a real alternative. So as I said, when we look at our patients, we look at the patient from a point of view of anatomy, pathology, physiology, and cooperation. But there are other significant factors that impact outcome. And this is what Jared Mosier has referred to as the dangerous airway. So again, collectively, there are patient issues and there are environment issues. And these environment issues, I've already talked about equipment. Support is a huge issue about who can come and help you and taking care of that patient. But then there are provider issues. So you have to have the appropriate skill to take care of this patient. And emergency medicine is full of what people call high acuity, low opportunity challenges. That's emergency medicine, right? And we can't sort of say, okay, well, you know what, it's not part of a skill set that we need because it doesn't happen that often. I truly believe if you're going to be an emergency physician, you want to ensure that your training program gives you the opportunities to make these halo challenges something that you can overcome and you can leave with competence and the ability to perform these procedures successfully. The challenge is the way in dealing with these halo opportunities, you have to overlearn. And what we mean by this is you can't just sort of attain competency. You have to have really achieved some sort of skill mastery to the point that the mechanics of these procedures are automatic. Right, so you don't have to think when you're operating a flexible intubating scope of whether your thumb goes up now or down, and you know where you depress the suction port and how you move left or right with rotation of your wrist. Right, you have to have those features down so you can execute it in that high acuity setting. Now the challenge that people have, okay, well, how do I overlearn something that doesn't happen that often? We have to really move ahead of what we thought was the key to procedural skill competence or performance. It's not about numbers or time, really. It's about deliberate practice opportunities. And what deliberate practice means is it's effortful practice. It's not easy. It's not easy to acquire these experiences, but you can do it. There's ways that you can do that for every type of procedure. So you can attain that skill set that you need to look after that patient. Now let's think about the awake intubation. Most patients that need an awake don't like lying down, right? They're in respiratory distress, so they got upper airway pathology. So now you're going to have to do, your laryngoscopy. And I suggest that if you don't have a flexible intubating scope to do this, then probably using a hyperangulated video laryngoscope is the way to go. Some people will disagree with me on that, because I think it's the most comfortable for the patient. But there's still the mechanics of it. The patient's sitting up. You're to the left of the patient's head, often up on a stool, with your right arm around, doing what we call precision laryngoscopy. So you as opposed to what you're used to is operating from the head of a bed. So you have to train, right? You have to have those mechanics so it feels comfortable to do it for you to have that success. In the same way, we all shit on the use of mannequins for teaching, but again, learning how to do a face-to-face flexible approach, You can nail down your mechanics. Probably takes you about 100 goes on plastic to get the mechanics down, right? To know how to manipulate the scope up, down, rotate right, left. And there are other simulators that are out there that can help you really cross the learning curve that you need to do. We've got the great fortune of again using cadavers, but this is what effortful practice is finding those opportunities. So at the end of the day, assuming that we do have the skill and that we do have the equipment and the gear, do we need another option? Or is the Awake and the RSI enough to manage the patients that are in front of us? I'm not sure. And I really do think that we do perhaps need something a little bit more. So let's go back to our algorithm. Again, I'm not saying that this is an algorithm that people should use, but this is the one that we use. And you assess the patient's anatomy and pathophysiology, and you assess them as being a difficult tracheal intubation, and the patient's uncooperative. Next thing you're supposed to do in this state where you've got a difficult airway and they're uncooperative, you say, okay, if I can't tube them, am I going to be able to oxygenate them with bag mask ventilation? And hopefully, if that fails, with rescue oxygenation using a supraglottic airway. But if I feel that that is unlikely, then it's really not advisable to go down the RSI route. And if this patient is truly uncooperative, an Awake option's really not there. So this is where in our algorithm we list other options. Whenever your algorithm says C text, it's never good. And this is perhaps the role of ketamine-facilitated intubation. So let's look again broadly at sedation in airway management. There's sedation-facilitated airway management, otherwise historically deep sedation. There's ketamine-facilitated intubation, and these two, I think, are different. And then there's the Awake intubation. This is in brackets because you may or may not use some form of sedation, usually anxiolysis, sometimes analgesia, and on occasion, you do need to dissociate your patient. So sedation-facilitated intubation, this is what we've been saying for years. Some people agree, some people strongly disagree. That it has none of the safety benefits of an Awake intubation, none of the facilitated conditions of an RSI, and all the undesirable reflexes such as gag and potential laryngospasm, cough, and whatever are still in place. And so we've referred to it as no man's land. And there's been quite a bit of literature on this. Multiple operating room studies with experienced physicians using big-time doses of induction agents, propofol, big-time doses of accompanying narcotic, without the use of neuromuscular blocking agents, and almost always they show poor intubating conditions, poor success rate when compared to the use of paralytics, and higher complication rates. Now again, there are many people who believe that they have had a different outcome when they've employed sedation-facilitated intubation. This is a review article from the clinics of critical care, and they describe it as graded sequence intubation, again using ketamine or using other sedatives. I'm not a big fan of having new terms, but it's a worthwhile read for sure. But my feeling is, and many of us feel, that deep sedation or sedation-facilitated intubation is really potentially playing with fire. I do think that there is a role for ketamine-facilitated intubation, but I'm going to break it down really into two categories under ketamine-facilitated intubation. There's a dissociated Awake approach. And what I mean by that your primary approach is that you're going to attempt to do an Awake, and you're going to topicalize for laryngoscopy, which requires application of the 5% ointment, the way we suggest anyway, to do it to the posterior tongue and allow that to sort of melt down into the vallecula so that they can tolerate the laryngoscope. And then applying atomized lidocaine to the glottic inlet and to the trachea, allow them to tolerate the endotracheal tube. And in this patient population, and it could be upfront, that there's no question that this patient is truly uncooperative. You might have to dissociate that patient, or but yet might have to do it so that you can do proper topicalization. I'm not doing it as an alternative to topicalize, to use ketamine, right? I'm using it to facilitate it. And or again, I could say I might be able to topicalize that patient, but you know what? They're one of these people that their gags just aren't going to allow me to do it, and this will happen. I might dissociate the patient at that point, or I might dissociate the patient later on, just to tolerate the endotracheal tube, right? But the primary approach is to do a facilitated, awake, using topicalization as the primary approach, and I may dissociate that patient. If I dissociate that patient as part of it, it's a dissociated awake intubation. The other group is the true ketamine only intubation, and this is the scenario, particularly in pre-hospital, where you just don't have scope of practice to do an RSI or to do an awake approach. And there are two camps. There's a camp out there that's feeling that pre-hospital, depending on provider skill and what the success route is of the organization, that intubation shouldn't be part of scope of practice, and it should be bagging the patient and placing supraglottic airways. And others who feel very strongly that intubation should be part of that scope of practice. But how do you deal with the issue in terms of what other options that they have, and that their traditional fentanyl midazolam route perhaps isn't the best? Does ketamine offer an advantage? And I don't know. Maybe it does. There are several jurisdictions that I know that are in the process of switching over to ketamine alone for the pre-hospital systems, and I really look forward to hearing what they're going to. What their results are, and they're gonna publish their results. So what do we know? We know ketamine is very effective from an evidence point of view for pain. We know it's very effective from a behavior control point of view. We know it's effective from procedural sedation and analgesia. What about to facilitate intubation? There's very, very little evidence, despite the fact that I think it has been used for some time by a number of groups. So the advantages of ketamine theoretically is that it provides excellent pain control. Your patient's going to be unaware, and they're going to maintain an awake-looking level of consciousness. But be clear, I don't think that we should call this patient awake, the dissociated patient awake. They are dissociated. They don't have respiratory depression. Apnea is uncommon unless you administer large doses quickly. What evidence is out there is poor in terms of success rates. Really no better than what's been published using other sedation-only facilitated intubation approaches. But again, I think that there are people that are having higher success rates, and I look forward to reading those publications. Let me skip to the potential for laryngospasm. It is rare, but if it were to happen in a patient that you're worried about their airway, it obviously would be a disaster. The more common scenario that I think is a real one, and I do believe you're seeing that in Ruben's video, I don't think it's uncommon that tone is increased in general in patients that receive ketamine. And that doesn't matter when you're busting pus, draining an abscess. But if I'm doing laryngoscopy, having appropriate mouth opening to do good laryngoscopy, particularly if you're using a Macintosh device, you really do need cooperation or relaxation to do a good laryngoscopy. That's my feeling. So when to do a KFI, I like the way they presented it in their algorithm, the way Ruben and Michael and Andrew presented it. Similarly, in our approach, I think it's for patients potentially with difficult tracheal intubation who are truly uncooperative, and you also don't think that you'd be able to bag mask ventilate them or place a supraglottic airway. And it is the best of the alternative options. I'm going to finish off with this is how. And this is what's different again, and this is what the way I would favor using the term awake and dissociation in the same title. A dissociated awake approach is that what you're doing here is you're routinely looking at the patient. You might judge them as being uncooperative, but your approach is going to be similar to doing an awake, right? You're going to try to topicalize their posterior third of the tongue using your ointment, and you're going to try atomizing the glottic inlet and the trachea, so they will tolerate laryngoscopy and intubation. But I might use ketamine along the way, right? If they can't tolerate the topicalization process. So just like a DSI, right? You're doing it to pre-oxygenate your patient. You're doing it so that the procedure is to facilitate topicalization, right? Or again, that they're the patient that you've topicalized, but their just gag is just, it's one of these people that they gag when they brush their molars, and you know what? Sometimes that will happen and it will fail. You might dissociate that patient, right? Or you might dissociate them just during placement of the endotracheal tube. But your primary approach still is an awake one. And the reason why that is important is to really, if you're doing an RSI, I don't care what's on your name tag, whether you're a RT, an emerge doc, a paramedic, flight nurse, it's as long as you're experienced, you've got the skill set to take care of that patient. The same way it goes when you're doing an awake approach. And if I keep it simple, is that my approach is RSI, or awake, and that awake might have to turn into a dissociated awake approach. Then we're gonna be able to have that skill set to employ on the patient that presents with the difficult pathology, difficult upper airway anatomically challenging cases, as opposed to sort of saying, here's another pot that we might enter and it's ketamine facilitated, where our primary approach is ketamine, and then we just atomize near the end for them to tolerate the endotracheal tube. My fear is that because that's the easier of all three approaches, that's what people who feel uncomfortable with doing an RSI, don't feel that they have the skill set or equipment doing an awake, people are going to dump into that category, and we're going to go backwards in time. And that's one of the concern that I have. I'm just going to go back to our book, aimairway.ca/book, Airway Management and Emergencies, the Infinity Edition. What's nice about our book is that, when papers like Rubin's comes up, I can go back in that night and change the content and upload his reference. And then after I get permission, include his algorithm, and we have a link to the paper that's there. But even before I did it, this is what was in our section on ketamine. Currently, there's very little published evidence supporting KFI in terms of safety and efficacy. It may be that KFI can fill the void of options that plague emergency airway management for patients in whom risk versus benefit assessment favors a non-RSI approach, and an awake approach isn't feasible. However, at present, there is no literature to support this strategy. And hopefully, users of this approach will share their KFI experiences in the published literature in the near future. When I go into the woods, I go in with my mentor, and we go in with minimum 3 saws, if not 4. And those saws have different purposes. I've got a small saw that if I'm up in a tree or up in a ladder, I can handle easily. I'm not using my great big heavy saw. If I'm taking down a big tree, I've got my big saw. And if I'm junking up in my backyard, my firewood, I've got yet another saw. And the saw that I'm going to have soon is this is the Still 880. It's the biggest one that they make. And I'm going to use it for a completely different purpose, to make live edge slab wood. So again, if you're going to have real options, make sure you have a toolbox with the right gear in it, and you've got the right skill to use the gear that's in it. Take care.